So Mrs. Lara, 38 years old, female patient, complain of loose motion. Her vitals, blood pressure 130/85, her pulse 115, temperature 37.2, respiratory rate 16, saturation in room air 98. Proceed, doctor.
Hello,
Hello?
I'm Dr. Marghani. I'm a doctor in the clinic today. Can I confirm that I am talking to Miss Lara, 38 years old?
Yes, I am.
Miss Lara, we are here today to discuss your health condition. I'm going to ask you some questions, examining you and address your concern. Is that okay with you?
Yes, okay, doctor.
Okay, Miss Lara, can you tell me what brought you to the clinic today?
Actually, for the last 2 months, I have been complaining of loose motion.
Okay, Miss Lara. Is it the first time you have such loose motion?
Yes, first time.
And now, is it progressing, becoming worse or the same?
I feel it's the same.
Any day-night variation between this loose motion? I mean?
No, no,
Okay. Do you observe that anything make it worse, like a specific type of food, maybe?
no, I didn't notice that.
Anything improve it, like fasting?
No,
You mean it is there all the time?
yes,
Can I know the frequency? How many times per day you go to the toilet?
about 3 to 4 times.
Can I know the amount by estimation? How many? Yeah. Is it large
It's
amount?
no moderate amount.
Any offensive as abnormal?
No,
Is it difficult to be flushed?
no,
Does it containing any blood or slime?
no,
Any associated tummy pain?
no tummy pain.
Any alternating time with hard motion or all the time it is loose?
No, it's always loose.
How are you compensated by this? I mean, your appetite is good?
Appetite is very good, and I am drinking a lot of water to compensate for this loose motion.
Do you notice any weight change, like any loss of weight or something like?
Although I am eating well, I feel my weight is decreasing.
Sorry for that, Miss Lara. Any weather preferences, Miss Lara? I mean, do you prefer hot weather more or cold weather more?
I don't like hot weather.
Yes. Do you feel that you have excessive sweating than normal?
Yes, I feel that also.
Any shaking in your body and your hands specifically?
Sometimes I feel that.
Do you observe that you have any eye change? I mean
No.
that you have gritty sensation in your eyes or that your eyes became out.
Greatest sensation, yes, I feel, but I have no affection on my vision. I see well.
Any double vision in any direction?
No, I didn't notice that.
Okay. Any pain in the eye or any redness?
No,
Yes. Do you feel that you have any lump or bumps in front of your neck, maybe mainly?
I feel that because my cooler, it's not like before. It's became tighter.
Any pain during swallowing?
No,
Uh-huh. Do you have any racing awareness of heartbeat, Mrs. Lara?
yes,
Yeah. Can I know if it's it regular or not? If we tap
it
like this or abnormal or irregular rhythm?
it is regular.
Mm-hmm. Is it most of the time, even you are asleep?
Yes,
Okay. Any associated chest pain?
no,
Any breathing difficulties?
no,
Uh-huh. Okay. Any cough?
no.
Yes. Concerning this loose motion, does it awake you from sleep at night?
Because of I'm drinking a lot. Yes, I used to get up from sleep.
Mm-hmm. Okay. Do you feel any feeling sick or being sick?
No,
Yeah. Okay, Miss Lara. Can I know, do you have any problem in your water work? Amount, maybe frequency?
no,
Do you feel any weakness in any part of your body?
no.
Any joint pain?
I have joint pain in my knee,
Both knee or one?
in both knee, on and off.
It is on and off, yes.
Mm.
Can I know any skin rash or skin change by any mean?
No,
Did you feel any tiredness?
I feel weak. Yes,
Yes, you mean you feel weak. Any problem when you are standing from sitting position or trying to lift heavy thing, combing
no, I
hair?
don't feel. No,
Mm. Okay, any abnormal sensation in your body anywhere, like
no.
any numbness, any like this? Okay, okay, Miss Lara. Can I know any lumps or bumps anywhere in your body?
Apart from my neck, no,
No. Okay. Any leg swelling or
no.
okay, Miss Lara. Can I know what are you do for a living?
I am teacher.
How much is this affect your job and activity of daily life?
Last 2 months is because of loose motion, continuous, so much effect.
I'm sorry for that. We can help you by contact you with the occupational health services in this regard. Is that okay?
Okay, doctor.
Okay. Any past medical history of note, Mrs. Lara?
Yes, I have diabetes and
Mm-hmm.
hypertension, high blood pressure and high blood sugar.
Okay. Can I know since when you have the diabetes?
Since 6 years.
Is it controlled?
Yes, controlled.
By which medication?
I am taking metformin.
What about the high blood pressure since when?
Since 3 years, I am taking candizartan, and it's controlled also.
Also controlled. Do you feel any dizziness when standing from sitting position, Miss Lara?
No. Also, I have a
Mm.
fracture before in my leg, and I am taking a non-steroidal.
Okay, sorry for that. Any heartburn sensation or like this
No.
from this non-steroid? Okay. Any family history of note, like thyroid
Uh,
diseases, heart disease?
my sister has hypothyroidism
Uh-huh.
and nothing else.
Okay. Any problem in your sleep, Miss Lara?
No, I'm sleeping well.
Any anxiety attacks?
No.
Mm-hmm. Okay, Miss Lara. Can I examine you?
Okay, doctor.
Yes, I will check Miss Lara general appearance about weight loss. Is it of
Okay,
observed weight loss?
she looks BMI about 18 and vitals the same.
Vital the same as it is regular pulse. I will check for capillary refilling to assess her hydration position. Yeah.
Okay, listen to second.
Okay. After that, I will go and see her eyes for any exophthalmos, any lid retraction.
Do you want to check the hand first for thyroid status for the patient?
Yes. I will check for sweating in the hand and tremor
Yes.
by
Okay,
put the hand in a pillows. Yeah,
what you want to check exactly, and I will tell you if there or
I
no.
will. Yes, can stretch your hands out like this to check for any fine tremors.
Yes, you found fine tremors.
Yeah. Okay. Sweaty. I check the palm for sweatiness, palmar erythema.
Yes, sweaty.
Any palmar erythema.
No,
Any finger clubbing.
no finger clubbing.
Yes. After that, yeah, I can go and check her blood pressure. Yes, as outside.
Pulse also, doctor. Check the pulse.
First, yeah, I asked about pulse. You said to me normal volume.
No, you have to check. Ask history. You have to examine now. You are in examination.
Yeah, okay. A pulse is like outside.
Yes, but I mean, she told you it's regular, but you have to examine. You may find irregular, you may find
Yeah,
AF.
I will
You got
check
my
the
point?
pulse for
Mm.
rate and
Mm.
yes, Regularity, rhythm.
It was regular and equal on both sides. Okay.
Okay. After that, I will check her blood pressure. Now, is it
Still 1 point in hand examination. Don't miss.
by synchronicity apart from?
Temperature. You have to check temperature of the hand.
Yes.
Okay. Then you will go to, you told me you want to check blood pressure. It's the same.
Yeah.
And
Any collapsing?
no collapsing pulse.
Yes. Okay. After that, I will go to examine the eyes. Okay.
Okay.
For any eye change, like any exophthalmos.
What you want to examine in the eye?
I will examine for the any protrusion of the eyeball, any lid lag, lid retraction.
So how you will examine for proptosis? What is your position?
Yes, I will be in front of the patient and first and looking for his if the eyelid doesn't cover the ball of the eye. I mean the whitish of the eye is it clear during looking for the eye? Any starring look?
This is for lid retraction.
Mhm. Yeah. After that, I will check for lid lag by asking the patient to look up, following my finger. And after
Okay.
I will do down, I see there may be any lid lag that delay in the
Delay in the
down
down
of the
of the
eyelid.
upper lid. Okay. So for you have to examine for lid retraction, exophthalmos, lid lag. This is from front. From behind, you will examine for proptosis. Just
Proptosis, yeah.
yes, you will be on the back of the patient after taking permission or telling him that you will come to the back, and he will
Mhm.
extend his face
Big-
back. Okay, and
I will look
see
from
if there
over,
is any.
yeah.
Yes, and continue your examination.
While I am in the back, I will take the chance and to, yeah, I maybe check for the thyroid. After before the eye, I complete the eye. I do yes eye movement to look for any ophthalmoplegia or double vision during movement of the eye in H
Okay.
shape.
Yes.
Yeah.
No, normal. Okay.
No. What about the lid lag, the protrusion? Is it there?
No,
Any feature or in the eye?
no.
After that, I will ask the patient to take sip of water to examine for thyroid movement in
Okay.
enlargement by inspection.
Yes, there is enlargement.
Yeah. After that, she can take a sip of water and to swallow it. Is it move with swallowing?
Yes, move with the swallow.
After that, I will check for the consistency and tenderness of by behind of being behind the patient. Is it a
Mm.
smooth surface or nodular?
Okay. So you will examine it to check if it's diffuse or nodular. Okay.
Yeah,
Then
diffuse or nodular. After that,
mm.
is it hard or smooth or yeah,
Yes, you'll do palpation for the surface nodularity of the and the tenderness. Okay.
and the tenderness. Yeah.
What else you will do?
Okay, I will auscultate for any bruit over the gland.
Before auscultation, you will do something.
Yes, I will check for any lymph node in beside the thyroid.
Yes, lymph node important. One important before auscultation.
Yes, for retrosternal extension also, I will percuss. You mean?
Yes, you have to percuss for retrosternal goiter. Yes, and
Yeah,
auscultation for
for
Berwi.
bruit. Yeah.
Okay.
What is the positive finding?
So 13 minutes now exactly, doctor.
Yeah.
Okay, you
Yes.
have to continue.
What positive finding in this thyroid examination? Is it smooth or nodular?
It's smooth and diffuse, and there is no retrosternal extension and no
Hmm.
Berwi. Okay.
Okay, I will check
So
quickly for any heart murmur or heart rhythm abnormality.
normal,
Yes, I can check the lower limb for any pitting edema or peritibial exedema or like this.
normal. You
Okay,
have
what concern you, Mrs. Lara?
what do I have, doctor?
Mrs. Lara, after what you said to me and after I examine you, most probably you have a condition that called hyperthyroidism. which is a condition in which the gland in front of your neck produce excess amount of hormones, and resulting
Okay.
in the symptoms that you have. So we need to run for you some investigations to confirm the diagnosis, and after that we can involve a specialized team for further management plan. Yeah.
Okay, doctor. Okay.
Mhm.
Thank you. Time, doctora. Well done. Very well done, wallahi, doctora. Very, very small point I will mention at the end. Or if you want me to
Yeah.
comment now. Okay.
Yeah.
Okay. Just only you have to ask about smoking because it's very important in
Yes.
case of Graves
Yes.
or any thyrotoxicosis. Okay. And also, just to continue the question of compression, let me mute.
Apart from
You.
swallowing difficulty, they have to ask about
I will mute all, doctor, and you do unmute later. Okay.
yeah.
Okay. Smoking, and you have to continue the question of compression. You asked only difficult in swallowing. You have to ask about any change in voice or any difficult in breathing also. Okay. So, what are the differential diagnosis for this case?
Differential diagnosis for this case, I didn't ask about female history to check her, delivery recent or like this.
Yes, this will we will comment on this.
Okay, my differential diagnosis could be hyperthyroidism due to autoimmune,
What else?
like Hashimoto's thyroiditis, maybe.
No, what else other differential for thyrotoxicosis? Not what is the causes of thyrotoxicosis. You got my point?
Okay. For this, it could be pheochromocytoma by this,
Okay.
symptoms.
You asked about anxiety and asked about
Yeah.
whether
The
and this. Okay.
Yes, and okay. Uh, Other could be due to maybe carcinoid syndrome, maybe
You
caused,
did
yes,
not ask about noisy chest or flushing. So any
flushing,
watery
yes.
diarrhea, yes, yes. Most common two cases in exam and long clinical consultation. Watery diarrhea, either Graves or carcinoid. Either Graves or carcinoid. This is the most common. So you
Yeah.
have to ask about noisy chest and flushing. Okay. What else? Differential.
Other differential,
Here is the problem, doctor, of the for me in the first three skills, you will mostly take full mark for examination, for managing patient concern, and for communication skill, because you asked about history and past medical history and the social. So you will here is a differential, okay, and identify physical signs. The problem always lie. So what else differential? You got my
um,
point?
ye- I got your point. Differential diagnosis for this thyrotoxicosis, you mean, yes?
Yes, we told carcinoid, you told pheochromocytoma.
Pheochromocytoma.
Both are right.
Mm-hmm.
You can put also microscopic colitis because the patient is using a non-steroidal anti-inflammatory for long time, or side effect of medication like metformin. These are
Yeah.
the okay. But always thyrotoxicosis, always differential as a case of watery diarrhea, carcinoid, and pheochromocytoma.
Yeah.
Thyrotoxicosis and pheochromocytoma sharing a lot of symptoms. Okay. What are the investigation you will do for this patient?
I will do for her a basic investigation in form of complete blood count, inflammatory marker, liver function test, renal function test. I will do for her also electrolyte, serum electrolyte. I will do thyroid function test, looking for, yes, T3, T40, thyroid stimulating hormone. I will do 24-hour maybe urinary catecholamines for pheochromocytoma, and also 5-hydroxy tryptamine for the carcinoid.
Now
Yeah,
you are to rule out. Try to organize
ruled
it.
out,
Basic investigation to confirm diagnosis, investigation to rule out
rule
other
out
differential,
differential diagnosis. Yeah.
investigation for complication to be more organized. Basic you finish. What investigation to confirm this is hyperthyroidism?
I will do a thyroid function test.
Yes.
Yes. And yeah.
What do you expect to find TSH?
If hyperthyroidism, the TSH will be low,
And if T4 will be?
and the T4 will be high. Yeah.
If TSH is low and if T4 is normal, what you will do?
If what? Again, sorry.
If TSH is low, but if T4 is normal, what you will do?
T4 is normal. I will do
You will
T3
do,
should be checked.
yes,
Yeah.
you have to do, yes, T3. Okay. So thyroid function test, what else?
Okay, I will do okay, ECG also for yeah.
No, you are in the area of thyroid now.
Fair. Yes, I will do for the thyroid also. Yeah, thyroid scan,
Yes.
and also I may need to do for her also biopsy or like this. Yeah,
Biopsy according,
to
no,
the
you did
scan.
thyroid function test, you will do thyroid autoantibody, you will do ultrasound, and the most important, thyroid scan. If this
Yes.
is Graves, what will be the scan?
If Graves, there may be high uptake.
Okay, if there is no uptake, it most likely
Maybe go with malignancy, maybe.
postpartum thyroid, any
Or
thyroiditis,
post,
subacute or thyroiditis.
yeah, subacute,
If
yes.
it's patchy, it will be
If is it patchy uptake,
nodular.
maybe
Yes,
multinodular, yes.
multinodular goiter. Okay. So, okay, well done, doctora. So, what are the treatment for this patient?
Multidisciplinary team approach, and yes, I will educate the patient counseling about her condition, and
Mm,
yes, occupational health worker maybe needed psychosocial, and after that I will involve a team of gland doctor, yeah,
mm.
for her condition, maybe need gut doctor also. After
You
that,
are
I will,
you are in
yes,
the area of non-pharma, right? Non-pharma
yes,
now. Okay.
non-pharma by multidisciplinary team approaches. Non-pharma also smoking advice to stop smoking, and also, yeah, uh,
Smoking cessation is very important, excellent,
yeah,
and eye care also,
eye
because
care,
if there is any proptosis or something ophthalmos, lubricant and these things.
grapes,
And
yes,
what
if
is the
grapes disease.
pharmacological treatment?
Pharmacological antithyroid medication, there is, yes, carbimazole or propyl thyracil can be used
Mm,
as
okay.
antithyroid, yeah.
If the patient is pregnant in first trimester, what you will do for her? You will give,
Yes, first trimester, propyl thyracil is is the first line. After
and
at the first trimester, we can change to carbimazole.
if she's still not responsive to propyl while she's pregnant, what you will do?
Mm-hmm. I don't know really.
Okay, don't know better than telling give her iodine. Okay, because
Yeah,
the trick
لا,
here,
contraindicated, yeah.
yes, contraindicated. What are the indication of surgery?
Indication for surgery, compressive symptoms,
Mm, excellent.
um, cosmetic reason maybe if patient
Yes,
needs.
maybe patient preference. Okay,
Yeah. After that, unresponsiveness to medication
okay, or contraindication to
or
radioiodine.
contraindication to radioiodine. Yeah.
Okay, so one more question: are you aware of types of thyroid cancer? Question asked before.
Yeah.
Mm,
There is the papillary carcinoma,
mhm.
cancer, follicular, medullary, and lymphoid. Yeah.
Okay, anaplastic, and this is the last one. The most
Anaplastic.
serious is anaplastic. Papillary
The
is the
most
most
benign is the papillary. Yeah.
common, yes, about 70, and the follicular to about 20. These account for 90%, and the treatment by either radioiodine or by surgical removal.
Yes.
Follicular, this is will be with Hashimoto's thyroiditis. Okay. What is the test you are following up the patient for recurrence of thyroid malignancy?
I will do calcitonin level. Yeah.
Calcitonin in case of medullary thyroid carcinoma.
Thyroid cancer.
Other one you will do thyroglobulin. Okay,
Thyroglobulin.
thyroglobulin. Now I am covering all question can be asked in Graves' disease or any thyrotoxicosis case. This case is common as a long. It can come in Irish as a short. There is one case in miscellaneous and endo station, Graves' disease, and these all the question can be asked. Last question, doctor. If the patient is thyrotoxic and now is euthyroid, what are the possibilities?
Could be Hashimoto, could be subacute thyroiditis. Yeah.
No, the patient already thyrotoxic. Okay. The patient is already thyrotoxic and they came after another. Then came he's controlled. Okay, maybe he's a euthyroid. Sorry, when you examine his hand, you found him euthyroid. What are the causes?
Well controlled, maybe with the medication.
Yes, well controlled or development of cancer. Cancer also will make the thyroid status will be euthyroid. Okay.
Yes.
So well done, doctora. Good analysis for loose motion. You did not miss any part in it. Okay. Only a very small point you miss in case of, as we mentioned, that you did not. So
I
in your,
look in front of my in my paper traveling history, I miss it here. Yeah, I didn't ask.
I will tell you now
Yes.
about traveling history in any case of suspected infection.
Yeah.
Like high grade, like fever, like lymph node, like water diarrhea. You have to ask about quickly about travel history, sexual history, exposure history, these things. Okay, but there is some difference between UK approach and Irish approach. In UK approach, you have 5 minutes. Prepare scenario you can put from the beginning outside a list of differential diagnosis to ask. Okay, in Irish he will go inside and he has a long time, so he has to ask about everything. In Irish, he has to ask even because he has a lot of time. He can ask every system by all questions in the system. Now in abdomen, he will ask about upper GI, lower GI, and hepatobiliary. All of these questions. For you, the only missing part, carcinoid. You did not ask about noisy chest and flushing. Important to ask about the smoking. This is very important. You pick up thyrotoxicosis, you jump immediately, and this is very good. Tonic swelling, and you asked about also the vision, very important. You asked about the skin changes, and also you have to ask about nail changes, this clubbing, acrobacy, or something like that. Okay. And the greatest sensation you asked about, and very important to ask about pressure manifestation. This is very, very important. Okay. And in treatment, DC smoking is very important. Okay, doctor? Do you have any question?
Yes. No, thank you, doctor. Thank you for the chance. Yeah.
Anyone want to ask any question?
Sir, what was the part? What did you say when you said that TSH is normal, low, and T4 is normal? What do we do then?
T3, free T3.
Free T3. Oh, okay.
Yes. Okay.
Okay, doctor.
Yes. تفضل.
If he is not, you said if he is not controlled on provide thyroxine in the first trimester, what will be add iodine?
No, iodine is contraindicated in.
I think surgery.
Yes.
What?
Yeah.
Iodine is contraindicated in pregnancy, okay, or in eye symptoms. The tricky in this question, the examiner will ask you about the patient is pregnant, what you will do. Everyone knows that probile thyroxine is given in first trimester, okay? So he will ask you, then she's not responding to probile thyroxine. Everyone will jump immediately to iodine. This is the trick because she's pregnant and it's contraindicated. So just to take care about this.
Surgery is indicated, huh?
Yes. Surgery indicated when there is contraindication to radioiodine. And there is some precaution for radioiodine if you know, rule of 4 days away from children, 4 days away from pregnant, 4 weeks away from children, and 4 days away from normal population. 4 weeks away from child and pregnant, and 4 months away to be pregnant. Okay, this is the precautions if she took radio iodine.
Doctor, in this case, what about celiac disease? Am I supposed to ask about it or no?
She asked already in relation to specific food, bile bulky, offensive, difficult to flush. She asked about malabsorption, diarrhea. She asked
Doctor,
About HIV also? Risk of
HIV. Yes, we told in any case of lymph node, fever, or diarrhea, you have to ask about sexual history, travel history, exposure history to animal or to sick patient to exclude infectious causes.
Doctor, excuse me, you said 3 T3. I didn't understand what is 3 T3. T3, yes,
Three.
because yeah, it could be isolated high T3. But what is 3 T3?
No, I didn't say 3 T3. Free.
Uh-huh.
FREE.
3
T3.
T3. Okay, I understand now. Thank you.
Okay.
Excuse me, sir.
Okay.
If you told if TSH is low and T4 normal, then what it could be? So I couldn't understand.
You are trying to rule out any something like toxic adenoma or T3 secreting tumor, something like that.
And the second question is, as you told that propyl thiouracil in first trimester, if patient is not responsive, then what we can give? Carbimazole give or?
You can give carbimazole, yes, because it's not absolutely contraindicated. But the most important, don't give iodine. This is only trick in the exam because everyone will jump to giving iodine. What is the same action? Carbimazole and propyl thiouracil, mostly the same action. But propyl thiouracil, you have to give a lot of number of tablet. Any other question before we go to the other short clinical case? Dr. Azhar?
Yes.
You will be the one, right?
Yes.
Okay. So it is neuro.
It's a neuro. Okay.
Yes. So you, I think you no need to take time, or if you want 1 minute or so, it's up to you.
Okay, we can start. No problem.
Okay. Neuro case. Examine lower limb for this patient.
Okay. Can we start?
Yes, start.
Okay. After entering the room, first I will see what is the instruction of the case. Then I will wash my hand with sanitizer. And then I will introduce myself to the patient that I am Dr. Azhar. Today I am in the neurology ward. I want to check your lower limb. Is that okay with you? I will take
Yes,
permission
okay.
of the patient. And then I will stand on the foot end of the patient and I will have a general look. In the general look, I just want, I will ask the patient, please, can you remove your trouser up? And
Okay, it's already.
Yes, and I want to see any scar, any deformity.
Okay, doctor, I will put the picture for you. Okay.
Oh, okay.
Can you see it now?
Yes, I have seen.
Okay. You found this patient. Also, you found ankle orthosis beside the bed.
Ankle orthosis. Okay, ankle orthosis only beside the bed. Okay. Okay, I will start. First, I will check the tone of the patient.
Okay. You will do by inspection. Okay. You can comment on what you found inspection. These two pictures.
Yes, I can see there is there's an inverted champion.
Okay.
There's a wasting of the lower limbs. It is especially at the distal end. I can see, And
Here.
and on the, if I see the fit, there is a pes cavus bilaterally
Yes.
and the hematose bilaterally I can see.
Okay. Go on, doctor.
Okay. I want to check the tone, then I will check the on. I will start with the tone of the patient. Tone is normal or not.
No hypotonia.
Patient is having hypotonia. Okay, then I will check the power of the patient.
Power is weak.
1 minute, I just want to write. Patient is
Okay.
hypotonia and power is weak. Okay, I want to check the reflexes.
Okay.
And
Hyporeflexia also. Hyporeflexia.
and hyporeflexia bilaterally.
Yes.
Okay, then I want to check the sensations. I want to check the sensations with cotton wool, light sensations.
Okay, you found all sensation or modality of sensation are affected, decreased.
And then the pinprick sensations are also decreased
All
up to which
modality.
level?
All
Up to which
modalities.
level they decrease?
Up to his knee.
Up to knee. And likewise, the position and vibration sense is also decreased.
Yes, also.
Okay, then I want to check the coordination.
Coordination intact.
Coordination intact. I want to check the planters.
Downgoing plantar.
Plantar downgoing. Okay. I want to check the upper limb for any problem. I want to
Also,
complete my neurological examination by checking the upper limb and the cranial nerves.
oh, okay. Cranial nerve normal, but in upper limb also you may find wasting in his distal hand.
Distal hands. Okay. So I think I also want to check the gait of the patient.
What do you expect the gait will be?
The gait I will find there will be a high steppage gait maybe.
Yes, because of foot drop. Yes.
Yes, there's a foot drop. There will be high dropping gait, foot drop.
Okay, so
I think I finished my
yes,
examination.
because simple case. It's you'll diagnose it once you will enter. If you
Yes,
see this case in front of you, you'll diagnose it once you
yes,
enter.
yes.
So present your case.
I have seen a young person who is having weakness and wasting of his distal leg muscles, and also the tone is reduced and power is reduced bilaterally, and reflexes they are downgoing. Reflexes are depressed, and all sensations are reduced up to the knee level, and planters are downgoing, and a patient is having foot drop, due to which is a patient gait having the problem having of the high steppage gait. And also in the upper limb, if I will check, there is also wasting on the uh, distally. I think I forgot to check the rhombic sign. Should I go for a rhombic sign?
Yes, but you may ask because it will make like the patient you will stand and like this. Sometimes the gate and the rumbage, he will not allow you. Just you mention it will be positive, sure. Okay.
Okay. So the most probably my diagnosis is it is Charcot Marie tooth disease on the basis of the my examination.
Okay. So
And
what are the differential?
my differential will be, it may be a Friedreich ataxia, but in Friedreich ataxia, I cannot find any distal weakness and wasting of the muscles. And uh, the other, it may be post-polio syndrome, but the post-polio syndrome, it will be unilateral, it will not be bilateral. And
And
it may be due to
other. Yes.
it may be due to diabetes mellitus, but in diabetes mellitus, I cannot find this pes cavus and hematose, and there will be no wasting and fasciculations in the distal end. There may be, I can also found this is a chronic inflammatory demyelinating polyneuropathy, but against CIDP, I could not find all these pes cavus and hematose and distal wasting. In hereditary ataxia, and there may be hereditary ataxia with the neuropathy, but the condition is not favoring this hereditary ataxia.
Okay. Finished all sensory motor neuropathy like diabetes, chronic renal failure, vitamin B12 deficiency, and all of these both in your differential. Okay, what you will do investigation for this patient?
Besides the basic investigation like CBC, ESRC, reactive protein, and liver function tests, renal function tests, most important, I will do for the nerve conduction studies and to see the function of the nerves. Then electromyography, EMG, I will do. Then biopsy of the nerve, I can go. And then
What is
I can
the
also
nerve?
do,
Which nerve you will take biopsy?
biopsy of the, I think there is, I forget.
Do you remember the name? Okay, sural nerve biopsy.
Sural nerve biopsy,
Okay.
biopsy. And to confirm my diagnosis, I will do the special genetic test I will do. And
Okay.
high resolution ultrasound of the nerve, I will also can do.
What about type 1 and type 2 for in Charcot Marie? Are you aware of finding in nerve conduction?
No, I do not know.
Okay, no problem. Type 1 demyelinating, type 2 is axonal. Okay.
Type 1 demyelinated.
Yes. Type 2 axonal. And what are the treatment?
Treatment is generally it is supportive. I will make the pharmacological and non-pharmacological education and counseling about the disease, and I will make the multidisciplinary teams like physiotherapists, occupational therapists, and neurologists and the specialist nerve, and then I can also involve the orthopedic surgeon and orthotist and genetic counselor.
Yes. Okay.
And the treatment basically it will be sportive treatment. There's no specific treatment, and the basic function of the sportive treatment is to prevent the development of the contractures.
Yes, excellent, Dr. Azhar. So what are the other causes of bilateral biscavus? This patient has bilateral biscavus, which indicate long-standing condition. What other causes?
Yes, nephritic ataxia of the biscavus. Most important cause is nephritic ataxia.
Anything else? Do you remember?
There may be spinocerebellar ataxia or a beta lipoproteinemia, maybe, but I'm not sure.
The majority will be long-standing, either hereditary or congenital or something. So causes of bilateral biscavus, one of them is Charcot Marie tooth, Friedreich ataxia, as you said, myotonia dystrophica, cerebral palsy, hereditary spastic paraparesis. All of these can cause bilateral biscavus. Can you mention one or two of unilateral biscavus? One is very common. Yes. One is very common, and you see many times in the street or in your hospital.
No, I don't remember. Unilateral.
Polio is one of the causes of unilateral. Yes, unilateral biscavus, the patient short limb and
maybe in polio.
Unilateral, only unilateral.
Oh.
Okay, and if burn or malunion infraction. So well done, Dr. Azhar. This is case Charcot Marie teeth, one of the simple case, because you'll diagnose. Once you will enter the room, you'll diagnose the patient. Very, very distal wasting, foot drop biscavus, clawing of the toe, or before we are calling hammer of toe.
Yes.
What you are telling, doctor?
No. Can you repeat the causes of bilateral biscavus?
Okay, bilateral biscavus to memorize. All of them are long-standing. So either Charcot Marie teeth, which is hereditary motor sensory neuropathy, or Friedreich ataxia, or myotonia dystrophica, cerebral palsy, or hereditary spastic paraparesis. Syringomyelia also can cause sometimes. Okay, these are the causes of bilateral biscavus. Okay, so in hereditary sensory motor neuropathy, it like this disease like the peroneal muscle. That's why also you are calling peroneal muscle disease or peroneal muscle atrophy. And in the upper limb, it like the ulnar nerve. That's why you may find the claw hand. Okay.
Yes. Yes.
So the typical feature will be distal wasting, you will inverted champagne bottle, and there will be bilateral biscavus and photo drop. There will be hypotonia, hyperflexia, and there will be decrease in modality, all modality of sensation, high steppage gait, and there will be positive Romberg test. There is no definitive treatment, as you said, doctor, only supportive and depend on non-pharma, like patient education, patient counseling, physiotherapy, occupational therapy, neurosurgery, and neuro and ortho, and these things. And you will give him walking aid or ankle support or the foot orthosis. Okay. Any questions?
No, thank you.
Anyone want to ask?
Yes, Dr. Omran, sorry. Just because I want to ask regarding the examination basis. The short case in neurology, if he will tell me examine the lower limb, also I will go other neurology, I will go to cranial nerves, upper limbs, and this, or only I will go to for the lower limb.
Just you will examine the lower limb, but you will mention, as Dr. Azhar mentioned, I want to complete my examination. It will be by examining the cranial nerve, upper limb, and the gait.
So I will mention only.
Just only 6 minutes. Sometimes you cannot finish all the examination in 6 minutes.
Yes.
Because what is happening, you will find 6 minutes pass. Okay. Now he will start question immediately, because the station is 10 minutes, 6 minutes for examination. When you will go and you will search for the hand gel and this about half minute pass, then you will pass 13 seconds in general survey. At least you are trying to find something, and also you want to show the examiner that you are doing general survey for any clue for your case. So you still have 5 minutes only to finish your examination. In high, do check tone, power, reflexes, coordination, and sensation. Here, because we are talking, it didn't take time, but in the exam, real exam, it will take time.
Of course, yes. Thank you, Dr. Omra.
Dr. Khaled, if the examiner asks what is the differential in this case, I can say it is Charcot Marie, Frederick ataxia, hereditary spastic paraplegia, myotonic dystrophia, cerebral palsy, and Jesseringio.
This is because of bilateral behaviors, but it's better to put other causes of lower motor neuron like hypotonia, hyporeflexia, and these things in the form of sensory motor neuropathy, like diabetes, chronic renal uremia, chronic renal failure. I mean, vitamin B12 deficiency, these things, vasculitic neuropathy. This is should be. He will not let you. يعني 3 to 4 differential but strong is better than 100 differential far away. Okay, Dr. Azhar?
Yes. So there was interruption of your voice. Can you repeat when you told diabetes mellitus uremia?
Yes.
Next.
Vitamin B12 deficiency, diabetes, uremia, vasculitis. 4 is enough.
Okay. So I can put these 4 in differential.
Yeah.
But if the if examiner asks differential diagnosis of pes cavus, then I will say is the Frederick ataxia, hereditary spastic paraplegia, myotonic dystrophia, cerebral palsy, like this.
Yes, because hereditary spastic paraparesis and the Frederick attacks, there will be upper motor neuron spastic. You will find hypertonia and hyperflexia. Different finding. Okay, but only bilateral biscavus they are sharing. Okay.
In this case, we can also put one differential with alcohol and amyloidosis.
And alcohol, yes, alcohol. Yes, alcohol.
Okay. Alcohol, amyloidosis, yes.
So
all causes of predominantly sensory loss we can put here.
Yes, sensory motor.
And motor, Guillain-Barré, CIDP,
yes.
lead poison,
this is pure motor. Better to put sensory motor better, because Charcot Marie is sensory motor. So you put all other sensory motor. Wide list for this. And some drugs also can cause sensory motor neuropathy. You can put. Okay. Any other questions?
Thank you very much. Dr. Talab,
uh,
in the first case of hyperthyroidism, that was a female. So I think we should not forget about this
pregnancy.
female history,
Yes,
drugs,
she,
periods,
Dr.
pills, and pregnancy. Maybe this is a case of postpartum thyroiditis.
Yes, Dr. Sausan, she mentioned at the end that she forgot to ask about the 4B, pregnancy, abortion, pills, and OCB. All of these you have to ask also, right?
Thank you very much.
One more question regarding this thyroid case. If the patient is coming with the symptoms of loose motion, in examination, will we do abdominal examination or just thyroid examination only?
Because you pick the case, you may only do for thyroid examination because time is very limited, and I think examiner will understand this point. Okay, for thyrotoxicosis can come by palpitation, can come by weight loss, can come by loose motion, a lot of complaint, but the end result will be thyrotoxicosis. So be aware of this.
Okay, thank you, doctor.
Okay, Dr. Sausan, she did a good thing. She asked about signs of dehydration. She examined for signs for dehydration. She examined for capillary refill. She examined for blood pressure sitting and standing. And just you can add also any dryness in mucous membrane. This is important because you are dealing with watery diarrhea for a long time.
Yes.
Okay. Any other questions? Okay. Okay. Thank you. We will end. Assalamu alaikum wa rahmatullahi wa barakatuh.
وعليكم السلام. Thank you.